Red eye, say, just again to refresh your anatomy. I don't think I need to go in detail. I'm sure you all can look at that maybe. Yeah. So 4 conditions generally come into your mind: conjunctivitis or corneal pathology, uveitis or acute glaucoma. So you take a history about where there is a discharge. Because the discharge itself will tell you whether it's watery or mucousy or purulent, then you can look at if it's a purulent, of course it's a bacterial. If it's a mucousy or watery, then it's a viral or allergic condition. Then they can present with photophobia and painful red eye, then or it's a recurrent attack, then think about iritis. So from the history itself, a lot of information, which I don't see much in the referrals, so I'm sorry to say, but it's very informative if you can mention at least more about the history. And because I'm sure many of you all don't have slit lamp, but if you have slit lamp, that's an additional tool actually to give all the details. Then it's a blurred vision. Then pain, of course, acute glaucoma, this is how they present: severe headache, painful red eye, vomiting. They might end up in neurosurgery, ward also, because they think it's intracranial or hemorrhage or something like that, but eventually end up in poor vision, or there may be history of contact lens wear or trauma in the sense not physical alone. It could be a arc welding or it could be a chemical injury or whatever the trauma can cause. So examination, what you find, you check the visual acuity always. Please document that, because very important in terms of grading and triage actually, to see how sooner. Then look at the lids, looking for any swelling, redness, warmness, and tenderness, or maybe injury. Then looking at the conjunctiva for injection, that's an important sign in conjunctivitis, because if you look at the eye is red, you pull the lid, always pull the lower lid. It's easy to pull, and if the phoneal part of the conjunctiva is injected, means it's conjunctivitis. You can close your eyes and say, oh, this is conjunctivitis, because that's a good sign to know. And also chemosis when there is allergic conjunctivitis. I'll have some slides in here. Also, they can get purulent discharge or mucous discharge, crusting. Then you look at the cornea, looking for foreign body fluorescein stain, that always you do, and ulcer. And also ciliary injection, that means in the limbus, around the limbus, how the blood vessels are congested, as opposed to the rest of the bulbar conjunctiva, or if you evert the lid, tarsal conjunctiva will be okay, but the the limbal part will have injected. Then go further deeper and see. I'm sure you all need, I'm presbyopia, you all need glasses and probably some magnification to look at the pupil and the reactions and all. I guess you check a pupil in both dark and light, because the reaction to see whether they are reacting. Okay, these are some of the slides of in a child. You can see the lids are swollen, purulent discharge, conjunctivitis, so it's bacterial, likely bacterial, and then say it can present like this as well, right? So in herpetic condition, you get the vesicles, involving the lids with crusting and watery eye and red eye. Fluorescein stain, so aberrations you get with fluorescein stain, and also in herpetic you can get the base of the ulcer taking up the stain, so that and the particular pattern gives you a correct diagnosis then and there for you to start acyclovir topical 5 times a day. You can use it for a week or so, but by that time if there is no improvement, or if there's something getting worse, you can refer. So, and looking at the pupil, as I told you, darken in the light. Normally those who have anterior uveitis, they have small pupil and they don't react much, irregular pupil as well. So if you look at the other slide, this is the other acute condition, the acute glaucoma. This is very typical where patient present with a sudden drop in vision, severe headache, painful red eye, vomiting, and if you look at the cornea, it's hazy and ciliary injection, a lot of ciliary injection, and AC details you can't see properly. Mid-dilated pupil, shallow AC. You put your finger, close the lids and put the finger in there. It's rock hard. So that's acute glaucoma. So send them immediately. Then conjunctivitis. We look at pretty quickly of each condition. So the conjunctivitis, is a unilateral, and the main thing is the visual acuity is normal, cornea normal, and pupils normal in conjunctivitis. So that's an important part. But in adenoviral conjunctivitis, when it, say after 4 or 5 days, they can go into keratoconjunctivitis, where you can get keratitic precipitates causing photophobia, watery eye, and blurred vision as well. So what you do, you take a swab. Normally, it's good to take a swab. If you are very sure, probably not necessary, but if you are doubt, you take a swab, bacterial and viral. Nowadays, PCR, 3 days, the results are there, so you can deal with that. Of course, you are not going to give anything specific for viral conjunctivitis, but if it's for bacterial, so either chloramphenicol or fusiophthalmic would do. You can treat with. Okay, so I had to rush a little more. So this adenoviral conjunctivitis, where you get the keratitic precipitates causing photophobia, watery eye. Then the corneal pathology, dendritic ulcers, we already looked at, and associated with vesicles. Then if they present late, or if anybody have started some steroid drops, it can end up like a large ulcer. Later on, when they scar, this is how the herpetic, this is an extreme type of, if you don't attend properly, they can give corneal scarring and vascularization. So treat with topical, and those who are immune compromised, and if you have ocular surface disease, then they can present, you have to give oral acyclovir as well. That means you can start on that and send the patient, inform the. So bacterial ones, of course, it's a necrotic reaction most of the time, not every bacteria, but that's how they end up in getting a necrotic part of the cornea, which can lead to perforation. So that's why it's important. If in suspected bacterial corneal ulcer, please don't start on antibiotic. Send them immediately, because they are going to do the scraping and start on very intense antibiotic, because the results are misleading if you start on that. So send them within few hours to the eye clinic. Then the uveitis, it could be anterior, intermediate, or posterior, or maybe pan-uveitis involving, if the pars plana is involved, it's intermediate uveitis. So as we already looked at, ciliary injection, small pupil, so irregular pupil. And if it is severe, when they present at a later stage, means, you'll end up in keratitic precipitates. The endothelium will have all these precipitates called keratitic precipitates, or they can present with hypopyon, so pus in the anterior chamber. So just to go through what then there are systemic association of this condition, this uveitis. You can look for in ankylosing spondylitis and psoriatic arthritis and juvenile idiopathic uveitis. Say the vascular conditions like Behçet's, and then you can get in sarcoidosis, then syphilis. Obviously, tuberculosis nowadays is coming up, people coming from, where it's prevalent, you can get tuberculosis, so keep that in mind as well. And the inflammatory bowel disease, Crohn's disease, with all these, systemic manifestations. So what we do when they come, looking for, do this test, and how do we treat? first line of treatment is topical steroids. Then if that doesn't respond well, then you go into periocular intravitreal steroids. Of course, we had to have cycloplegia because the patient, to relieve the pain, because the ciliary spasm in uveitis causes the pain, so tropicamide or cyclogel is helping in that way. Then also to prevent adhesions, because of inflammation, they can develop pupillary adhesions. If they are severe and not responding, then you go to immunosuppression systemically. So using systemic steroids, and all these biologics nowadays, it's quite handy to have a good control. Then this is how you give the injections. So I'm just rushing through. If you don't treat uveitis, you will end up like this. You get cataract, glaucoma. Then you get band keratopathy of the cornea, then macular edema. These are some of the common complications they can end up. So basically, you can lose that eye or sight of that eye. So the last one is acute glaucoma. It's more serious than the other conditions and can damaging, or it can damage pretty quickly. So you already looked at, sudden drop in vision, painful red eye, mid-dilated pupil, hazy cornea, and tender to touch. So it's sudden onset. Just keep in mind anticholinergics, you might use it frequently in the form of antispasmodics, so tricyclics, or antihistamine, and muscle relaxants when you are on, that can sometimes precipitate glaucoma. We'll leave that chronic glaucoma open angle because that's a different topic and it's not an acute problem anyway. So risk factors for acute glaucoma, if anybody coming with thick glasses, long-sighted people, hypermetropia, they are in 50, 60 age group, and if they just keep that anticholinergics in mind, and the ethnicity of Far Eastern or Indian Asians. So this is some of the slides. What does it do in glaucoma? So it's a pupillary block. So what happens, you get pupillary block, and so that leads to the narrowing of the angle and closure of the angle, the sudden buildup of pressure that present as a acute glaucoma. So you have to break this cycle. That's what we do. So what we do, say these are the presentations, and so urgent referral. So we reduce the intraocular pressure using intravenous acetazolamide, and to use a pilocarpine to constrict the pupil to draw it away from the angle, then aproclonidine and timolol to reduce the pressure. And sometimes to reduce the pressure, you have to use mannitol. Then you do the peripheral iridotomy. This is what we do. At the periphery, you make a small opening, and that's how you treat. So that's a laser-mounted slit lamp. So you can see the peripheral iridotomy nowadays we do at 3 o'clock meridians. So these are the causes of. Then there are other causes. Probably just I will tell. These conditions also can cause red eye, allergic conjunctivitis, episcleritis, and scleritis. They present like that. So you can use optichrome, bromide. Mainly the lid. If you invert, you can see the papillae or follicles. That gives you. Then the episcleritis. Of course, don't get panic. It's a common condition, self-limiting. So just use some tear substitutes, which should do.